Got it. All right, everybody online, thank you very much for joining. Appreciate it. Dr. Yazel, State EMS Medical Director, is going to be doing a discussion. This is actually part of my personal 2024 EMS goal for Union Hospital. So when his presentation is done, there is a slide on there that's got a barcode or a link. Please do me a huge favor, go out there and answer the 2 questions that are out there. Don't need names, don't need anything like that. Just answer the 2 questions that are out there, and I'll get those sent to me. That way I can keep track of, so I make my metrics for my goals. So appreciate it. I'm gonna leave it up to Dr. Yazel to go from now. So
Awesome.
might use the arrows.
Oh, sorry.
Might be easier for you.
Hey, everybody, this is Eric Yazel. I'm your State EMS Medical Director, if I haven't met you before. And thanks for giving me the opportunity to talk to you. And I know out-of-hospital medical arrest probably been talked about a lot, but I think there are some new things and some important things that are worth hitting up. Is everybody automatic muted, or can they ask questions and stuff?
I don't think they're automatic muted.
Good, okay, so that's what I was gonna tell you is I don't know that I'm great about checking the chat, so if, as long as you can unmute, feel free to blurt out questions, interrupt me, stop, ask for clarifications, anything like that. So please don't hesitate to do that. I always say that I'm not one that likes to stand up here and drone on and on and on. So really, don't hesitate to ask if I can help with anything. Oh, I want to. There we go. Whoa, take off. All right, so I say, geez, it's sticking. That went like 10 slides deep.
Wow. Sorry.
Oh, you're good. I think we're good. All right. So I would say it's kind of like Groundhog Day. I do feel like, in EMS, we're probably always guilty about trying to talk about the more interesting, cool things. And so we end up talking about out-of-hospital cardiac arrest a lot. But I do think there are some things we could do better, and with better attention to detail, you really will see impact in your ROSC rates and things like that. And more important than just ROSC is your rates of people walking back out of the hospital too. So that's why I wanted to kind of focus on this, especially Indiana's becoming a CARES registry state, so we'll get a lot more data on ROSC rates and things like that. And so I think just really pounding home some of the fundamentals of out-of-hospital cardiac arrest care is really important. So one thing I say is, every aspect of healthcare has something that is their thing. And I think cardiac arrest for EMS is our thing. That's what we do and should be best at, and and set the standard for everybody else in the community. And so that's why I think, again, it's important. The first thing I always like to talk about is who do we resuscitate? Who are we going to work on? And first and foremost, the 3 things to consider when you're out in the field: if it's unwitnessed arrest, no shockable rhythm, and you don't get ROSC in the first 10 minutes, there's less than a 1% chance of success. So, those 3 things, when you walk into an out-of-hospital cardiac arrest, those are 3 things you should be thinking about right away. Was it witnessed? How long have they been down for? Have they ever been in a shockable rhythm? So that's one of the first questions. Say you arrive on the scene and there's a different first responder there, or an AED on the patient, that should be your first question. And then if you work for 10 minutes and don't get anything, less than 1% chance of success. So let's kind of talk about that first, but let's talk about the ones that we are going to resuscitate. And one thing I always say is the ones we are, ACLS is for people who don't routinely practice emergency medicine. I don't know who said that, so if I keep presenting this and nobody ever claims it, eventually I'm going to claim it as my own. But I know I heard this somewhere, and I can never find out who said it. But what I always say is ACLS is for like the ophthalmologist office that wants to be able to respond to something. Somebody collapses in their waiting room, waiting for EMS to get there. It should not, that should be the lowest common denominator for out-of-hospital cardiac arrest. From an EMS side of things, ER side of things, I expect more for us, and that's why we're having this conversation today. One thing I always say is, there used to be this old debate. Some of these new folks probably don't even know the whole stay and play versus load and go debate that was a debate for 20 years. I think, a lot of our data now says that we should be staying on these scenes, at least until we get ROSC or things like that. And just for clarity, I'm talking more medical cardiac arrest, hospital cardiac arrest. Trauma is a little different animal. We kind of stay away from that today for time's sake. But a lot of times I say when we do that, so now we're staying on the scene and we're resuscitating, we've got to take responsibility for what that means. And what that means is we've got to be the best at what we do from the beginning to end. And I don't think we always take responsibility for that. I think sometimes we do a great job on, CPR aspect and things like that. But even, other stuff that you may not think about. Like how many of you have ever been trained on how to talk to a family? After you call a code after 10 or 20 minutes, now all of a sudden, yeah, your medical indication said you did the right thing. But you've got a family sitting in front of you staring at you while their loved one is laying there unresponsive and passed away on the family room floor. So there is a lot of responsibility that comes with taking, the scene management and staying on scene. That I think as EMS providers, we need to, make sure that we're addressing appropriately. One thing also, a lot of people talk about, has something been shown to be beneficial? And, I think that's really hard in out-of-hospital cardiac arrest to show things have benefits. There's so many confounders, every scene's different, downtimes, regional differences, different treatment arms, just all sorts of things. There's almost always a bias study, so you're never gonna get a great, study that says, like, epinephrine's a big one right now. Is there a lot, is there really gonna be somebody that approves a study that says, now we give no epinephrine no matter what to cardiac arrest? You're probably not gonna get that one approved right now. Maybe as some data goes on, and things like that, or certain types of arrest, yes, we're seeing that, but it's just really hard to prove things. So, when that's the case, you could either, I think number one, you have two options. You can focus on the fundamentals of what you're trying to do. And number two, you can do what makes physiologic sense. And I always say when you're in a code, defer to those two things and you'll go a long way. Of all the years and all the things that we have, we've done, all the treatments, ECMO, all the cool gadgets and things like that, truly the only two things that have been shown to be beneficial: electricity on them early and quality uninterrupted CPR. And I just can't stress the uninterrupted part of that enough. And I'll talk about that here shortly. There's a lot of talk about pit crew CPR. I think it's great. I think, efficiency in your resuscitation teams is important. On your scene, you're not always gonna have, people that you can pre-plan with and everything. So that's why I have that picture on the bottom. Always maintain some flexibility with your scenes. I think when people try to get overly regimented and structured, then when something interferes with that structure, it can really throw you off. And if there's anything we've all learned in EMS, every scene's different. Something unexpected always seems to happen. So, have a game plan, but again, don't be too rigid to it, and make sure you can adjust to the scene in real time when things happen. One thing I always like to show is ALS versus BLS, and always hear about not enough focus on BLS and some of the EMS lectures that are out there and things like that. Well, BLS, this is your time, because out-of-hospital cardiac arrest, a lot of the studies actually show better outcomes with BLS care than ALS care. And I think it comes back to focusing on some of those fundamentals and things like that. And again, when I say with power comes responsibility, at the ALS level, there are more procedures that you can do, intubation, access, things like that. But I think what tends to happen sometimes is CPR is halted during some of those, and it leads to poor outcomes. So, this is one where the BLS fundamentals are the key. So one rule of thumb I always say is if you have to stop CPR to do it, sit down and think about, should you really be doing it? Because chances are the data is not going to show a mortality benefit from it. And a lot of times when I always fuss at our nurses in the ER about, they're very regimented. Every 3 to 5 minutes, there has to be a pulse check. And if you try to get them to not do that, I get a lot of pushback. And the first thing I always hear is, I'm just following ACLS. Well, 2010 guidelines, so now 14 years ago, it's been there ever since, should be minimal interruptions in CPR. So you are following EMS when you do that. And then I always love to show this card, because I want everybody that's looking at this to take a look at this at this card. This is your old ACLS cards. I assume they still hand those out just like they always did.
Yeah.
Show me on there anywhere that it says stop and do a pulse check. Not a damn place on there, right? It asks you if there's a rhythm that's shockable. There's no pulse checks on there. So actually, when you stop and check a pulse every 3 to 5 minutes, you're actually not following EMS ACLS when you do that. So, and I'll explain more why that's important. I'm not picking on anyone. It's just that it really does decrease your chance of success if you rigidly are just stopping and checking a pulse. And so what did it say? Shockable rhythm, right? And so the pulse is not actually what you're looking for. You're wanting to remove all the hands from the chest and see what the underlying rhythm is, if it's shockable or not. You need to get electricity on them right away if they're in a shockable rhythm. That's the question you want to know. And then the other thing is you're stopping this life-saving procedure of CPR to do a pulse check. Does anybody know the accuracy of a pulse check? Anybody? It's about a coin flip. So about 4 out of 10 times you think there isn't a pulse when there is, and 1 out of 10 times you think there is a pulse when there isn't. So that 1 out of 10 times, I mean, that's obviously devastating for the patient. The others, when you think there isn't a pulse when there is, I mean, CPR can kind of mess with the coordinated cardiac output, but otherwise not the end all be all. But I think the take home point is you're stopping CPR to do a procedure that has about 50% accuracy. And then the length of time of the check. Sometimes when the adrenaline's going, it feels very short. I pulled the other day 3 studies from major level 1 trauma centers in the United States that measured what their average pulse check time was. And all of them were between, I think the shortest was 18 seconds and the longest was 26. It is always much, much, much longer than you think it is. And then, and we'll explain again why that's important here in a second. Yeah, so again, back to the whole coin flip and then put the sundial in to tell you like how long that takes to check a pulse there. And the other thing I say is we're not robots. Like, it should not be every 3 to 5 minutes, must check pulse, must stop CPR. If you have a reason to do it, a physiologic reason, you've seen something on the scene, by all means do it. But rigidly doing that only harms the patient. And I'll nerd out with this slide. This is one of my favorite slides. This is exactly why that not stopping CPR is important. So it takes a coronary blood pressure. The coronary arteries have to have a blood pressure of about 20 to have any chance of successful resuscitation. It takes about 2 minutes of CPR to get up to that 20, to kind of prime that pump to a blood pressure of 20. So on that top line, that's what you're seeing. It's about 2 minutes up to get to where that jagged line kind of evens out. When you stop CPR, it takes seconds, 8 to 10 seconds to go back to 0. So 2 minutes to get there, 8 to 10 seconds back to 0. So that top line is basically with your standard pulse checks. So they're doing, CPR, CPR, CPR for 2 minutes. All of a sudden you have that narrow window where you have enough coronary perfusion to get have success, and then you stop and start over again every 3 to 5 minutes. That bottom graph is when you have uninterrupted CPR. So you have your same 2 minute window to prime that pump up to about 20, and then you just stay there all the time until you stop compressions at the end. So see how much more time in B there that you spend in that sweet spot where you have a chance of ROSC. Anytime that in graph A that line drops down again, you have no chance of success. So in a resuscitation where you're stopping that frequently, you literally spend almost 0 time in a position of any chance of success. And I think if you guys pay a lot of attention to detail during your resuscitations and follow it like graph B shows, you'll see that in real time. You'll start to see better ROSC rates. Now, what do people a lot of times stop CPR for? Pulse checks we talked about procedures. Defibrillation, that's one I see a lot. Like, I don't know if you guys are out in the field and see this, but I know I see it in the ER all the time. What's the first thing somebody does when they say go ahead and shock and they start to charge the defibrillator? Everybody takes their hands off the patient right away and stops CPR. Pretty standard that happens. I always say if you can't trust somebody to say clear after that defibrillator is charged, they shouldn't be in the resuscitation with you in the first place. So, keep doing it until, let that thing charge, keep it going with CPR. Then the person who's manning the defibrillator needs to stay clear, then you can pull your hands off, totally appropriate. But a lot of times they sit there and pull their hands off for 30 seconds while somebody fiddles with the settings on the machine and things like that. So again, if you can't trust them not to shock you, then they don't need to be in the room with you. Ultrasound, I'm a big advocate of ultrasound use. I think we're gonna see it a lot more pre-hospital, but a lot of times I'll see it at like our trauma center I work at, where they're very good. They can get amazing views, but they'll spend a minute and a half trying to get some perfect cardiac echo view so you can see the valves and everything when we should be doing CPR. So, it's a quick look. You don't have to get an image for the textbooks. So when should you do a pulse check? The one thing I always say is, end-tidal CO2 should be standard of care in any cardiac arrest. And sometimes you'll still see, especially in our ERs, I think EMS actually does a better job than ER does about watching end-tidal CO2 during an arrest. But if you're doing CPR, you're plugging along, and all of a sudden you see an end-tidal go from 15 to 45, absolutely that is an appropriate time to check and see if there's ROS, because there probably is. Conversely, if you're powering along and their end-tidal hasn't moved from less than 10, probably no point in checking a pulse, because you're not going to have one. You're not perfusing. A cardiologist would probably lose his mind if you heard me say this next one, but sometimes when you're doing CPR, there's all the the noise with the waveform from CPR, but you can still sometimes see a change in the underlying rhythm through CPR. That's another time I'll say, hold on, hold CPR for just a second. Let me see what's going on with that underlying rhythm. Again, totally appropriate. What you're not doing is checking for a pulse. Oh, I don't feel a carotid. Oh, I'm gonna go down to their femoral. Oh, does anybody feel anything up there? You're just saying quick, what's that look like when there's no noise from CPR? Matter of 5 seconds or less. Other change in patient status, you see something else. Or I'm not saying you can never check a pulse. Like if you've been pounding away for 10 minutes, 15 minutes and never, stop to do a check, totally appropriate there. But I think you should have, instead of just a robotic, must follow this algorithm, use some sort of other physiologic thing or some reason to trigger a pulse check there. Again, 5 seconds or less. When we get to the ultrasound, really all you want to do is plop it on there and say, do you see a squeeze or no? And what's the underlying rhythm? That's all you're looking for. One thing I think we don't talk about enough when we talk about out of hospital cardiac arrest is interthoracic pressure. This is a physiologic thing, and I'm probably going to bore you with physiology, but I think it's really, really important when it comes to cardiac arrest and resuscitation. When you do, basically our interthoracic pressure should always be negative. And so anything that increases it changes the dynamic in there. The coronary arteries are the only arteries in the body that actually fill when the heart is at rest. Okay? Every other artery, when you push down with CPR, what are you doing? You are pushing blood to your brain through your carotids. You're pushing them down to your kidneys through your aorta, right? When you push down, you are pushing blood out to the rest of the body. The one artery that doesn't get any supply when you're pushing down is the coronary arteries. Those are actually the ones that matter if you're going to get ROS. So what you're really doing with compressions is you're perfusing those vital organs so that if you do get the patient back, they'll maintain kidney function, brain function, things like that. Absolutely critically important. I'm not minimizing that at all, but I think we focus so much on the compression part of things that we don't focus on the recoil part of things. And the recoil is when that actually increases the negative pressure in the thoracic cavity and pulls blood back into the coronary arteries. And that's actually what gets you your ROS. So compressions is preserving function. Recoil equals ROS is what I always say. And I always think about, like I said, we always just think about it's more than pushing down on the sternum and ribs. And also some people you're pushing on the left ventricle, trying to push blood out to the rest of the body. The actual position of the left ventricle is much more variable than a lot of people think about. So during a lot of CPR, sometimes you are not getting adequate pressure on that left ventricle. So really the most important thing you're doing at that time is the recoil and letting those coronary arteries fill. So that's actually the focus. So really should be thinking more about the recoil than you should be the compression part of things. So You don't have to remember all the physiology stuff, just remember recoil equals ROSC. So when you're pushing down, you've gotta make sure that you allow that recoil time. What's another thing that increases interthoracic pressure? That right there, intubation. Putting a tube down will increase the pressure in your chest, which is great. You know, from one side of things, great, you've got their airway secured, you know, you're getting good oxygen delivery. But if there's one thing we've learned from cardiac arrest over the years, it's that, you know, that's actually kind of de-emphasized as far as, you know, what gets you those ROSC rates. So actually putting a tubes down, sometimes increasing that interthoracic pressure actually allows less blood to return to those coronary arteries and can decrease your ROSC rates. And that's why some of those out-of-hospital cardiac arrest studies show some greater benefit, you know, with either bagging or with an i-gel or some other sort of laryngeal airway. I'm a big advocate for your LMAs, your i-gels on out-of-hospital cardiac arrest because I think it splits the difference. Provides some decent oxygen delivery, but does not increase that interthoracic pressure because it's not down into the lungs and things like that. So it still allows a decent amount of blood return to those coronary arteries. On the flip side, just bagging, number one, and we'll talk about this, bagging technique is very variable, especially with the adrenaline that happens during cardiac arrest. There's a big study, and I believe it was less than 5% of people get the appropriate tidal volume when they're getting bagged in and out of hospital cardiac arrest. It's either too much or not enough. It's kind of the whole Goldilocks phenomenon. And it's not there's operator error, it's just kind of a rudimentary tool. I mean, you're squeezing a bag, and I know some people advocate for pediatric bags and things like that. Doesn't really matter what the, you know, what you use with a standard bag, it is hard to deliver a reliable volume. That's why some of you have probably seen at some of the conferences and things like that, some of the bags that actually will allow you to adjust tidal volume and things like that. Their goal is to match it up to the patient better so that you're getting a little better delivery. So, you know, but I think that's the issue and why some of the studies seem to favor i-gel or LMA placement in out of hospital cardiac arrest for just that reason. The endotracheal intubation, number one, it increases interthoracic pressure. Number two, I see a lot of people stopping CPR while they're intubating. Again, if you have to stop while you're doing it, think about if you really should be. And then I already explained why the bag has some other things. The other thing I say is we're always in such a hurry to intubate sometimes. And I agree, it's nice to, I call it cognitive offloading, right? It's nice to get that tube down, get it secured, you don't have to think about it anymore. But you really, really need, what we're learning is to optimize those conditions. I remember back in the day, I used to say this all the time, where I'm like, thank God I intubated that guy. He was about to code. He coded like a minute after I intubated him. Well, he coded because I intubated him. You know, I always see the whole, don't just do something, stand there. Humans have lived for, you know, millions of years without all these medicines and procedures and things like that. So when we RSI somebody, we are taking away every inherent physiologic response this patient's having to whatever's going on with them, right? They have all this adrenaline going, they're tachycardic, you know, they're in respiratory distress or, you know, things like that. We RSI them and we knock out all that physiologic drive. And it makes it great for intubating, gives us these wonderful, pristine conditions, but it also makes them teed up for cardiovascular collapse as well. So, talked about the whole proven benefit. What ACLS medicines have proven benefit that have been shown? Really down to zero now. We still use epi, but there's actually a major study that just came out that showed no outcome improvement if there's a shockable rhythm. So even epi didn't help in a shockable rhythm. You know, and then the other thing I always said, it gets people into the hospital, but not out of the hospital. Epi has been shown, it can increase your ROSC rates, but it does not always increase your neuro intact survival. So you might, you know, get somebody up into the hospital, but their chances of actual survival are sometimes pretty slim. Now there are some factors that associate with getting somebody into the hospital that are beneficial. That are probably worth talking about, but at the end of the day, there is no proven benefit to it. You see it deprioritized. You'll see some resuscitation protocols that'll say give 2 doses of epi or a smaller dose, or some people are starting to go away from it a little bit. You're also seeing some people say, I'll try a dose or two of you know, code dose epi, and then they'll go ahead and start a drip. And I like that thought process for some reasons I'll get into in just a second. Like I talked about, it'll, your epi, sometimes you'll get enough ROS that you'll get that last little bit of heart squeeze, but eventually that gives out upstairs in 24, 48 hours a lot of times. So what is it, why is that? What does it actually do? Well, it increases your contractility of your heart. So if you've got, that's why I like the drip in in certain situations, because sometimes the heart's it's trying to squeeze a little bit. It just doesn't have enough muscle or, tone to contract effectively. Well, an epi drip can help with that squeeze. So that makes sense. It also does constrict the blood vessels, all throughout the body. So it can get your blood pressure up, which sounds great and all, but what does that do when a heart's trying to pump against a higher blood pressure? Well, it increases your oxygen demand. Kind of makes the whole heart work harder and things like that. What does increased oxygen demand do? Well, it actually increases the injury to the brain, to the kidneys, things like that. So, the higher the oxygen demand and the longer you're pulseless, the more damage is going to occur. So that's why you may get a contracting heart on a patient upstairs who's, brain dead and in kidney failure and things like that, because that's the trade-off, is you've increased that oxygen demand. My thing is, I'm a big fan of, I would say, ride the lightning, defibrillate early. And, some of the things, there's been a lot of data on defibrillation itself, and especially pad placement. You're starting to see some studies that show that actually, instead of kind of your traditional pad placement, that sometimes the AP pad placement has some better outcomes in some studies, still kind of being hashed out a little bit. That can be challenging in certain situations because you'd have to roll the patient, put a pad on the back, things like that. But the one thing I say is, if what you're doing isn't working, try something different. Kind of like the whole Einstein quote of insanity is doing the same thing over and over again, but expecting different results. So if you have defibrillated a couple times and you haven't got them out of that shockable rhythm, then do something different. One of the first things I say is what's called vector change defibrillation. Just try a different pad placement. Put them somewhere else. Then this day, the whole point of defibrillation is that you're essentially resetting everything. It's like when something goes wrong with your TV at home or your laptop, and they say power up and power down. That's what you're doing to your heart. You're trying to zap it, you're depolarizing as much of the heart wall as possible, and then hoping that when it starts back up, that inherent cardiac rhythm will take over again. So the more of that heart muscle that you can do that to, the better your chance of success. So as you do, change those positions, the chances of finding a position that delivers the most energy is better. Especially in this day and age when, here in the United States, we're getting bigger and bigger over time, then I think, this is an important thing to think about. Because what we find in studies is a lot of times we get nowhere near the electricity delivery to that ventricle that we think we're getting. So, and then a lot of times what that is basically this is kind of the patterns that you do: anterior, posterior, or anterior, lateral. But a lot of times what this is a precursor to dual defibrillation. So you're actually going to do both placements. You're going to go, up on the one chest and down low, then your AP view as well. And the reason for that is the longer the resuscitation, the more energy it takes to successfully defibrillate. That because your heart has been sitting there, that oxygen demand, that heart just quivers, and it's quivering at 200 beats an hour and just using up all sorts of oxygen. The longer that goes on, the less likely you are to have successful defibrillation. Every minute you wait, you lose about a 10% chance of success. So, the longer that's going on, so it takes more and more energy, or not necessarily even energy, but more coverage of that myocardium, that heart muscle, to get that back up and going again. And so what you're hoping to do is, with those four pads on there, is just to increase that surface area that's getting electricity there. I hear a lot of complaints of, well, we gotta be careful because that'll blow the warranty for our defibrillator and things like that. I've heard that a lot. There's been some literature searches. There's never been a documented case of this happening, of people, hitting at the exact millisecond at the same time and it arcing through one defibrillator to the other. The one thing I see that I always get a little tickled at is when I've done dual defibrillation in the ER, I think it seems like the staff, there's an assumption that there's more electricity. Like everybody's really scared, like it's not 200 joules and 200 joules makes 400 joules. Like everybody seems really frightened by the idea. And it's like, it's the same shock. It's just more paths that are doing it. So there is no escalation in risk or electricity dosing or anything like that with it, so. But again, I think the take home point of this is, if you shock twice without results, do something different. You need to change it up a little bit. There was just a new study that came out that recommends in shockable rhythms, no meds, no epi or anything until 2 shots minimum. So they're saying zap them, go back, do 2 minutes of CPR, zap them again, then start thinking of meds. Some of the other, I think Rialto or some of those other successful pre-hospital protocols, they don't even shock right away. They do 2 minutes of CPR and then shock. And that seems really odd to a lot of people until you go back to what I was saying earlier. They're doing 2 minutes of CPR to get enough of a coronary blood pressure to have a chance of success. Then they're zapping. And, I think there's some physiology behind that makes sense.
They're not doing anything unless they have a Roscoe or a entitled twin or a big.
Yeah, I think that's important too.
Yeah.
I agree. Now, when you go back to I think it's an interesting point because you go back to some of the biases too. Some of these places that, say, oh, we've got a, 40 or 50% ROS rate that seems crazy high. Some of them are picking and choosing who they're resuscitating too a little bit. So, I do think that's interesting, and that's one you have to really nerd out on some of these studies to parse through. Now, I'm not saying they're not, that they're not having some great outcomes there. But some of them are, some of them immediately factor out the worst of the worst.
Yeah,
They're not in touch with exactly. I throw this in every lecture, any cardiac arrest, don't forget at some point to get an AccuCheck. There's nothing that'll embarrass you more is if, you're there and you've been resuscitating and say you even get Ross back for a little bit, and then all of a sudden you look and their AccuCheck's 9, something like that. There's an easy reversible cause that was right under your nose and you just got focused on other things. So I always throw that in there. Vascular access. I think this is interesting because this is where I think my approach has changed the most over the years. Back in the day when I knew a full arrest was coming up there, I would stand at the head of the bed with my blade in one hand, my tube in the other, and I would intubate them the minute they came through the door. Now, if I get the heads up that that an arrest is 5 minutes out, I get my central line kit. I have a nurse on one side ready to drill an IO. I have my central line kit on my side, actually opened up and everything kind of prepped. As soon as they flop that patient over onto the ED stretcher, I have them drill and I put a big FEM central line in the patient to give all my ACLS drugs through. And I think that's really, really important to get good, strong access in almost immediately. Never be afraid to use any pre-existing access, like our dialysis patients. I think that's a key one there. They're very sick at baseline and they go into arrest a lot. I think once you start dialysis, your 1 year mortality is almost 50%. And I've had people, really struggle getting peripheral access in a dialysis patient because they want to preserve their dialysis access. It's like, man, your number one priority is to get your code beds in. So don't be afraid to use those if you need it. You can always ask for forgiveness later. Airway, I've kind of talked about some of this stuff a little bit. It's just kind of gotten deprioritized. I'm not saying you need to forget about it, but now what I tend to do, my practice is come in, I get access like I mentioned, make sure you're doing high quality, uninterrupted CPR. If a few minutes passes and I'm comfortable that I've thought it through, that everything's kind of progressing a little bit on autopilot, then I'll say, okay, now I'm gonna go get their airway, but I do not stop CPR the entire time. Now it's annoying, I'm sitting there with a shaky head trying to fire a tube in, but it's better than stopping CPR. And if I can't get it very quickly, 20 seconds or less, then I stop and go back to just bagging, or I leave my Yazel alone or something like that. Same thing with ROSC. If I get ROSC on a patient, I'll let them sit there for 5-10 minutes before I secure their airway and make sure I'm optimizing all their hemodynamics, getting their pressure up, even give them a little push dose suppressor, something like that. You guys have all seen this when we've resuscitated somebody and they have a lot of ectopy and tachycardia and things like that. Then it kind of settles into a different rhythm. And just give it a little time for that physiology to settle out, then take their airway. Because if you do it too soon, sometimes you can, get them right back to a code situation again. I'll the one thing I'll talk about is bagging technique. That's one thing that I still see mistaken a lot in my out of hospital cardiac arrests. In fact, these are both pictures from the same patient here. The angle you're looking, I think, is a little misleading. But look at that first patient. You really can't see him cup those fingers under that chin, right? He's kind of just mashing that mask down on his face. And all that's doing is pushing everything in his oropharynx back into the back of his throat, and including his airway. In that second one, you can really see those fingers kind of digging in under that chin. And really your goal should be is to lift that chin up to the mask. So you're not pushing the mask down, you're lifting their chin up and then holding that mask tight. And if you are holding a bag to a face tight, it should be very difficult to do that with one hand. Almost, you almost shouldn't be able to, unless you really practice it a lot and things like that. So attention to detail on the fundamentals. Also attention to detail, I would hook the patient up to an oxygen source instead of just a face mask there. Some smart ass in one of my lectures like, oh, I'll go ahead and put them on oxygen too. Anyway, but attention to detail on that bagging technique can save you a lot of headaches over time too. All right, so you're kind of doing the fundamentals, you're doing CPR, you're starting to do your rhythm checks. And so let's talk a little bit about the actual rhythms that we're getting here. The first one I always say is if you can't recognize this one, I can't do a whole lot to help you. This should be pretty straightforward. And as we all know, honestly, not to minimize things, but your patient outcomes are relatively dismal when this becomes a lead. What's the one thing to do with this? Always check another lead. Make sure you never want to call it asystole when it's just something's unhooked or something like that. And also sometimes if you're in a situation where you have a gain, turn that gain up a little bit just to make sure there's not a fine VFib or something like that. Obviously with VFib, you're wanting to shock and shock right away. I am still a big advocate for lidocaine. It's kind of like what's old's cool again. I think it works so much better. It's actually interesting. Amiodarone, a lot of people, you hear it a lot in ACLS, cardiologists love it, and things like that. It's a good medicine in that you can give it in almost any arrhythmia and it's not going to hurt anything. But I challenge you to do a little bit of literature research on it. Almost anytime amio gets compared head to head with another drug, it almost always loses, almost every time. So I don't think the efficacy is quite there. Not saying don't use it. I use it, pretty routinely, but I'm a big lidocaine fan. And also, if you're not getting much improvement, I'm a MAG fan. I give that all the time too. One thing it's you're starting to see is esmolol, which is a beta blocker. And I did this talk about a year ago, and a cardiologist about threw a fit. They're like, "Why would you give esmolol in a cardiac arrest?" Well, I just talked about the oxygen demand that happens in a heart that's fibrillating, right? You've got a heart that's squeezing, 200, 300 times a minute, just quivering. That's like, I don't know, going to the gym and running on a treadmill full bore for 10 minutes. Your heart muscle, it's done for. There's just so much buildup of lactic acid and things like that. And then you throw an epi on top of it that makes it even more challenging. So esmolol actually kind of cools off the heart, slows down the heart rate, allows that heart a little bit of time to rest and get rid of some of those metabolic byproducts. And so what you're seeing is in VFib sometimes giving a big bolus dose of esmolol will prime it for successful defibrillation. So next I'll talk about PEA a little bit. And this is one that I think is really important, that I think we still make a lot of mistakes on. I think you still see a lot of 5H's, 5T's discussion. I have no problems with that. I think that's good to think about why they are on PEA. I prefer a little bit of to look at the shape of the PEA. Like a narrow complex PEA tends to be more of a mechanical problem. So you're thinking about a tension pneumo, is maybe one that you do bilateral decompressions just preemptively. Think about PE. You may see acute MI, you can get any kind of PEA with it. Tamponade is a big one as well. With a wide complex PEA, you're starting to think about your electrolyte stuff, some of the dialysis kind of stuff that I think about, where you get some electrolyte abnormalities, your sodium's off, really high potassium, things like that. But really where I like to parse out PEA is the difference between pseudo PEA and regular PEA. Now that is that's a big deal. That may be something some of you may be new to, some of you may already be privy to this, but pseudo PEA is basically where the heart is trying to contract. It is trying to squeeze. It just doesn't have enough strength to actually generate a blood pressure. So you'll see your heart trying to move. It's just not able to push out enough blood flow that you can feel that in a pulse check or check a blood pressure or anything like that. Regular kind of traditional PEAs, what I say is when you look at a heart, all you can see, the heart is not moving at all. All you see is a couple of valves just trying to flicker. There's no actual attempt to squeeze or anything like that. And so you've got one where the heart's trying to squeeze, it just can't squeeze hard enough. And the other one where all there is truly just a little bit of electrical activity. So that's why the one where it's trying to squeeze is called pseudo PEA. Well, the difference between that can be really profound. Look at the bottom of look at the bottom of that slide. Your mortality in true PEA is up to about 75%. Or I'm sorry, I think I actually worded that wrong. Their ROSC rates can actually in pseudo PEA managed appropriately can approach the rates you see in VTAC and VFib. So you have a real chance of success in pseudo PEA if you can just augment how that heart's trying to squeeze. Conversely, if it's traditional PEA and all you have is that little valve flicker, really your numbers are about similar to what you see with asystole. So the fact that we lump PEA all into this big kind of garbage bag of treating it all the same really is doing the patient a disservice, because the outcomes between those two types of PEA couldn't be greater. So the key is in pseudo PEA is to augment that squeeze. And that's why I like to put an epi drip on, going back to our epi talk. So you're giving a constant dose of epi, you're augmenting that squeeze, and a lot of times you'll augment it enough to actually generate a blood pressure. The other kind of PEA, there's really not much you're gonna do. Your mortality is extremely high. So you'll also hear this talked about sometimes as a subpulse. And it's very similar where you have electrical activity, but no palpable pulse. So same thing, you gotta just kind of put some gas in the tank. You either need volume or blood or pressors, like we mentioned with pseudo PEA. So you'll hear the term subpulse, and I use that a little bit interchangeably with pseudo PEA. So let's see what we got there. Is that bicarb? Bicarb's one that there's not really been shown to improve ROSC or any neuro outcomes or anything like that. I was always taught that epi doesn't work at a pH of less than 7.2. So that I have some guys that trained me that always advocated for an amp or two of bicarb to kind of, I guess, prime the pump to allow epi to work. Well, now we're not even sure epi works, so I don't know that the thought process is there on that or anything, but improved acidosis can decrease oxygen demand. So now the one thing I will advocate sometimes, if I'm pretty sure it's a medical cause of arrest, I will give an amp or two of bicarb, because there's a lot of different kinds of unintentional and intentional overdoses that can help. Tessalon pearls is one. That's one that people think is pretty benign, but especially in pediatric arrest, an ingestion as small as a single pill can cause an arrest. It is very responsive to bicarb. Back in the day when people used to be on your tricyclic antidepressants, your Elavil, amitriptyline, kind of things like that, bicarb would do that. It would help with those. So sometimes if you've got if your spidey senses tell you that it's a medical arrest and you're not getting much improvement with kind of the classic things, I don't think you're wrong to say, I gave a couple amps of bicarb. Now just blindly giving that every arrest probably isn't the right answer. Calcium, kind of the same thing, no survival or neuro benefit. It's the theme with all these beds now. But what it does do is it stabilizes cardiac membranes. So it augments some contractility. Again, if if it's a dialysis patient, or you get a pretty good history for cardiac issue, or somebody clutches their chest and goes down, then I don't think you're wrong in firing in some calcium in that situation. Again, after standard treatments haven't shown much improvement. That's the old, I'm probably getting old, none of you probably know what this is, but upper right is a Hail Mary pass Doug Flutie back in the day. So I need to get some new beams that are kind of have at least joined this millennium. But yeah, I always use calcium as kind of a Hail Mary in that situation. Another area that I think we could really improve on as providers is our post-arrest care. I see this in both pre-hospital and the emergency department. A lot of times when you get ROSC and you've got it for a minute or two, everybody just kind of takes a deep breath and kind of smoking and joking again. Everybody kind of chills out a little bit. And this is really where you need to kind of double down and make sure that you're optimizing everything. So this is an area that I think we could really, really improve on as pre-hospital care providers. Number one, there's a 40% rearrest rate. So, again, almost a coin flip that they're gonna go back out on you. Really need to optimize those hemodynamics. So, think about what you're doing as far as, do you need to, raise their feet to try to increase some blood return to the heart? Do you need a little push dose press or anything like that? The one thing I would say is almost every single ROSC I've ever gotten is tachycardic for a little bit after you've gotten ROSC, usually from the epi, things like that. And they'll be, it'll be 180, 190 with a lot of PVCs, just a real ominous looking rhythm. And I see people still this day get really in a hurry to treat that tachycardia. They'll get some cardizem or something like that. Let it be. That is just physiology rearing its ugly head. A lot of times that rate will go back and eventually you'll be pushing some atropine or something like that here shortly. So let that be. Now if it persists 5, 10, 15 minutes, sure, think about addressing it. But, sometimes just take a deep breath and have some patience. The other thing is just reassess these patients. I know everybody's been, there's kind of an adrenaline dump after you've gotten ROSC, but you really need to monitor those pressures and things like that, and make every preparation for them to rearrest, because chances are, that they are. It's very likely that's going to happen. So the other thing I think is a real point of emphasis that we can work on is just our transitions of care. Major target of improvement, and that handoff all the way through, handoff from EMS to the ED to the ICU. You guys have all been there. I think, and this really is more on the emergency department side of things. I think they get in such a hurry to move the patient over and, start the resuscitation, that they really don't hear a thing that EMS says a lot of times. And you guys are providing absolutely crucial information. Now, the one thing I would say is hang around for a little bit. Let them get their resuscitation going, either pitch in if they need the hands or just stand off to the side. Number one, it's a good opportunity for learning. Number two, you're available so that when they can take a deep breath and really kind of process what you're telling them, you may have to give your history. Again, I know it's frustrating, but, I do the same thing. There's usually when a code comes in, there's this huge flurry of activity. Boom, boom, you're doing all these things, you're getting you're IOing them, you're starting CPR, you're getting them on the monitor, it's loud. I don't retain a lot of what I hear in that first report. Once you get all those things going, it's a great opportunity to kind of turn back and say, okay, let's give a more in-depth history of what happened. And really, really take pride in your ED reports on these, because these are the things that are so key, and you're the only one who's probably going to relay this. I mean, if you're counting on family history, they're shell shocked at this time. You're not getting anything useful out of them a lot of times. So, the information you can collect at the scene and relay to that doc is hugely important, not just in real time for your care then, but eventually even when they go up to the ICU, because some of the decisions about how aggressive they're going to be for that patient really depends on things that you've seen on the scene at the get-go. So some things I always want to know is, what time did the call go out? What time did you get notified you're going out to a full arrest? And then what time did you make scene? And I always laugh because sometimes if there was a long time, I can always tell they're real hesitant to tell me. It's like, I'm not trying to get into you about taking too long to get there. It just helps me gauge, like if it's a 25-minute scene time and nobody was doing CPR, that tells me a whole lot more versus a 2-minute scene time and somebody was doing CPR when you got there. So I really don't care that it took you long. It's just I want to know, what was happening, how long they're potentially down for. Bystander CPR is a big one, that tells me, and especially if you can say, like, if it, looked like it had any quality to it or not, and things like that. What rhythm they were in initially and rhythms that they were in route, and then any meds you give them, which is obviously pretty self-explanatory. And then when you get, those are things I like to know right up front, even as I'm just first starting the resuscitation, those are things that I want to say, okay, I need to know these right now. Now, when I get a chance, say I get ROSC and I get a chance to take a take a deep breath and actually think through the case a little more. These are the things I like to know second is, what did the family say? Did they give you an events of the arrest? Was he outside shoveling snow and clutched his chest and went down? Was he found laying in a bathtub with a needle next to him? What can guide me on what may have happened? When's the last time somebody saw him? Did he collapse in front of his wife or girlfriend or something like that? Or, was it somebody that they haven't seen for 24 hours? Medical problems that they may have had and in recent medical issues. I always ask too, have they been feeling okay? Have they been complaining of anything? Stuff like that. When they were found. And then advanced directives. This is one thing I always get crosswise with staff with sometimes. I will kind of plant the seed of like, say we've worked somebody for an hour, we got them back, but I think it's real tenuous. And the first thing that always happens when I walk back to the room is like, did you make them DNR? And it's like, give the family a second to wrap their head around what's happened. Now, sometimes I'll plant that seed and say, so, we've worked him for a really long time. We do have a pulse back right now, but I'm not confident that's gonna last. Do you want to come in and say anything you want to say? And also, you need to start thinking really hard as if he or she should arrest again, do you want to continue CPR? And I give them some time to think about it. But those are conversations to be had. One whole, and I think I have a slide on this, but I really do think we do EMS a disservice on not giving enough guidance and training on how to have those tough conversations with family. I think a lot of people are, they're dialed in during code and everything, but then to have those family discussions either afterwards or even during a code, that's kind of an art form that takes years and years of practice to do correctly, or not correctly, because it's not a right or wrong, but do successfully and effectively, so. The other thing I say is after every single code, you should debrief. And I think still right now, I think too much debriefing tends to degenerate into a little bit of finger pointing, and it's not that. You should learn something from every single arrest that you're in on. It may be something small that worked, didn't work, something like that. Again, some way that you say, hey, I thought it was very effective that we brought the family in, to bedside so they could see how hard we were working, or hey, I pulled that eye gel too soon, or what, I think we took a little too much time with that pulse check. We had this rhythm, maybe next time let's try this. There was a study. Those are the conversations to have, in a collaborative way, and that's truly how you get better. And I think if you do this effectively, again, you'll start to see your ROSC rates increase pretty dramatically. The other thing, and I think I mentioned this at the very beginning, I think we look too much at ROSC as like the only measure of success for a cardiac arrest. Did you get ROSC or not? And it's a win-lose based on if you got that or not. And I even talked about with the epi saying, okay, sometimes it gets people in the ICU, but it doesn't get them out of the ICU. That's still okay. That's one thing I say. I mean, I know it's a big use of healthcare resources and things like that. But, also, what if it allows the son that lives an hour away to come up and hold his mom's hand and say anything he wanted to say before she passes away? That's still a win. So, and then also sometimes, just by getting him back and, getting him up in the ICU, even though there's no brain activity, organ donation, that can be very good for closure for the family. And also, obviously can save numerous lives and things like that. So, it's not always win or lose just if you got ROSC or if they walked out of the hospital. And the other thing is, when you look, I guess your decision point on how you felt like you did with that patient should be, like back to your debriefing session. Hey, were there a lot of things I felt like I could have done better or not? And that some of those decisions on what's going to happen, the patient's outcome, were made well before you got there. That patient was going to get ROSC no matter what you did sometimes. That patient was going to pass away no matter what you did sometimes. So as long as you are thinking about it in those terms and not so just, did I get ROSC or not? I think that'll be much better for your own, job satisfaction and things like that. And man, give positive feedback to everybody that's in it. If you're a medic, if your EMT is just pounding out good CPR, great. If you, vice versa, if you said, man, you really, great thought on that dual defibrillation, like, when you're recognizing things that were done well, regardless of the outcome, give that positive feedback. Now, I'm not saying, don't high five in front of the family if somebody passed away, like, hey, great job, but, later when you're defibrillating, or debriefing, not defibrillating, when you're debriefing, have those discussions and say, hey, I thought you did a really nice job, talking to, that patient's husband or whatever that looks like. Give that feedback. So I think it's really important, so. I think I've hammered out a good hour of your time. If you have any questions, I'm right here, available. Thank you. I hope that some of these, I know some of this is probably redundant, things you've heard before, but, I think number one, just, it's kind of like shooting a free throw and getting those fundamentals pounded in over and over again, and then mixing in some new cutting edge stuff goes a long ways. Yep.
Hey, guys. Everybody on, thank you again for attending. We truly appreciate it. Please take time to fill out the evaluation form that's attached to either this barcode or that link. I'm gonna leave it up for a little bit. That's really important to me. It helps me be able to gauge my metrics on meeting my goals and my objectives for this year. We have another one of these coming up in October and another one of these in November. We'll be talking about them in audit review and up on lectures. So again, thank you guys very much and have a good day.
Awesome. Yeah.